Hey, good morning. This is Dr. Nick Tulo, streaming to you live from New Jersey. So, I have a great case today. As you know, I'm a heart rhythm specialist. I'm a cardiac electrophysiologist, and I created ECG Academy for those of you who really want to learn electrocardiograms well enough to be able to tackle virtually any complex ECG. I'm usually talking about arrhythmias, but today I have a really interesting case. It's a 40-year-old fellow who came to the emergency room with chest pain. Now, any of you who work in emergency rooms know that usually when a 40-year-old comes in with chest pain, they're probably not having a heart attack, right? You start poking around at their chest wall because maybe they were cutting the grass and strained a muscle or something. So then you start thinking about acid reflux, but this was an interesting case and the history had a lot of information in it. So let's take a look at the history. Hey, here we are. So, actually, let me just get my microphone up there. I think that would work a little bit better. So anyway, let me show you the history. This was a 40-year-old gentleman who worked as an assistant principal in one of the local schools. He had no past medical history, but in fact really never liked going to see doctors. And he was on no medication, so he was driving home after a relatively stressful day, and he started to feel really poorly. He complained to his wife that he had pressure in the left upper chest, and he started to feel hot, although he looked cold and clammy. He had a little bit of shortness of breath, and his wife said that he looked very pale. Sound like a heart attack, right? But with a 40-year-old, you'd think really maybe something else is going on. He had no associated symptoms, and he went to a local Center, but they looked at him, and after just 5 minutes, they said, you better go to the emergency room. So he came to the emergency room. By then, the chest pain was nearly gone. Now, when you ask him about other symptoms, he admits that he's been urinating a lot and he's been very thirsty, but otherwise he was feeling perfectly fine. Now, when you talk about his social history, he is a current smoker, and he's been smoking for probably 20 years. A social alcohol user, no big deal. But when you ask him about his family history, it turns out his father had bypass surgery around the age of 40. That's usually a bad sign. Usually there's something going on when you have such a strong family history of heart disease. Well, the initial labs, as you can see on this page, his CBC was normal, and his electrolytes were fine, except his blood sugar was 400. And it turned out he hadn't eaten for many hours, so that was pretty much a fasting blood sugar. They did get a lipid profile eventually, and his LDL was only 109, but his HDL was really low at 24, and his triglycerides were over 800, and that was repeated, and that was a true value. Initially, his CPK-MB was a little bit high, 6.8, but his troponins were normal. And he was pain-free at that point, so they put him in the observation unit, but not before they got an ECG. So let's take a look at what the ECG looked like and kind of evaluate it, because they were kind of unimpressed with the ECG. Let me just turn this off here. All right. So here's the initial electrocardiogram. He's pretty much pain-free with this. Oops. Second. I have my little switch on the wrong spot there. I didn't want to be touching. Okay. So let's get back to that. So here's his electrocardiogram. And let me grab my pen tool. And we can see that he has a normal sinus rhythm with a rate that's kind of on the fast side. It's about 90 beats per minute. And the axis is on the left side of normal. It's isoelectric and lead 2 that gives us about -30. And we look at the precordial leads, and the R wave progression is kind of understated. It does have an R wave eventually. But when you start looking at anatomical locations and you take a closer look at the inferior leads, does anybody notice something? Well, I did, and looks like Dig Squire said Welland's sign. Welland's sign would be deep T-wave inversions in the anterior leads, but what I see is a very, very subtle degree of ST elevation. Let me see if I can make that a little bit bigger and zoom in a little bit. Okay, so we'll drag this over and just look at the inferior leads. So if you take the segment between the P and the T wave as the baseline, so it conveniently lands right on this heavy line, we can see about 1 millimeter of ST elevation in lead 2. The same thing in lead 3 and AVF as well. And so this was actually a subtle finding. No one made a big deal over it. But I was reading ECGs the following day, and then I was asked to go see the patient. And I was very concerned. And it turns out the doctors in the emergency room put him in an observation. And if I take the zoom off of this and go back to the history, so they got repeat labs, as we normally do. We'll repeat the cardiac enzymes after 6 hours. And you see that the troponin, which was normal when he first came in, is now quite high. It went from 0.001 and now is 0.272. And about 6 hours later, it was 0.354. And then 24 hours later had come down a little bit. Now, the CPK-MB also went up. It was 25.9 after 12 hours. And of note is that his hemoglobin A1C was enormously high. So this was a guy who actually has diabetes and didn't realize it. He was walking around with blood sugars of 400 when he presented, and he had a very high hemoglobin A1C. So what do we have? We have a 40-year-old with a strong family history. He's a smoker. He has diabetes that he didn't even realize. And he has very high lipid levels with a very low HDL, which is your good cholesterol. So, and if I forgot to mention, he's a smoker. I mean, talk about having every cardiac risk factor known to mankind. So he originally was given aspirin, and when I saw this ECG, I had them order a loading dose of Plavix, and his heart rate was still running in the 80s, 90s, so we put him on beta blockers and got him to slow down. So let me show you what the ECG looked like the next day. So what you see the next day is the ST segments have come down now. So they're no longer elevated a millimeter. I can make that bigger for you and drag it over. So the ST segments have come down. Now they're only maybe a half a millimeter elevated. But you notice something. Look at lead 2. And let me bring up the old ECG so you can compare. Hold on, I'm going to have to get rid of this. And we'll enlarge it so it's the same size. Drag it over. Okay. Now, what's the difference? Look at lead 2 here, and then look at lead 2 here. Anybody notice something? Yeah. He lost the R wave. There's no R wave in lead 2 any longer. And it looks like a Q wave. And in fact, in lead 3 really looks kind of like a Q wave as well. So it turns out that his echocardiogram showed normal left ventricular function. But we obviously felt that he had an actual STEMI, an ST elevation MI, that was pretty much over within 4 hours. By the time he got to the emergency room, his pain was gone, his STs came down, but he did something over here with his coronaries. So after another 24 hours, we got another cardiogram. And now what you see is he still has some Q waves. His STs are still down. But now he has some T wave inversion. And that's kind of how non-transmural MIs often wind up. I would imagine that maybe after a few weeks or a couple of months, he might actually regrow his R wave. But I bet you're thinking, well, what did the cath show, right? We brought him to the cath lab after 2 days. He was perfectly stable and had no pain at that point. So guess what? We're going to go to the videotape. So it took me a little while to be able to set this up. But we do have the cath films. And I want to play them for you so you can see what's going on. Now, for those of you who know how to read angiograms, you'll see that this is the left coronary shot, and I'll sort of like explain it to you. So you have I'll actually draw on this temporarily. So let me just change my colors here. So you have here the catheters coming in. Here's the left main from here to here. The left main splits into a very large circumflex branch, which runs down the AV groove on the left side of the heart, and then a very large LAD, which then splits into the main LAD and a marginal branch. Actually, that would be a diagonal branch. See that? I'm an electrician, not a plumber, but I'm trying to get you guys oriented. So at any rate, it's a diagonal branch. Let me just erase this stuff here. And then we'll play the film again, because there are a couple of other views. And I'll eventually show you what we were interested in. Okay, so there in the circumflex branch, there's a narrow area right here. Let me just get rid of that. So there's a sort of a complex plaque right in here feeding this very large circumflex, which goes down to the inferior wall. Now let me just keep playing and see what else we find. So here's a shot that's showing again that circumflex lesion. And this is just another view showing, actually, that one was pretty neat because it shows how large the LAD is, and it wraps around the apex of the heart here, which you can see. Pretty cool. But now they are really kind of concerned about this circumflex lesion. But when they got a picture of the right coronary artery, well, we'll get that a little bit further on down. Okay. Play it. There we are. So it's kind of hard to see in this view because the spine overlies it, but right here there's a lesion, and I will show you in a better view of the distal right coronary artery. Now that part of the right coronary, as you can see, branches off and feeds the whole inferior wall of the heart. And when they got another better shot, okay, so there it is. It's about, well, they figured it was around 75% or so, maybe even 80% right there. You can see it. So that was likely the culprit that became occluded and caused this myocardial infarction. Now, it's actually very common to see this scenario where you have somebody who has a really bad plaque and they have very high cholesterol levels and you have diabetes, you have all these risk factors. And then what happens is that plaque becomes unstable and it can rupture. And then what happens is you get platelets that adhere to it and cork off that vessel. So platelets adhere, they occlude the vessel, you get the pain, the diaphoresis because of adrenaline release, you get all of the classic signs of an acute MI. But then what happens is the vessel spontaneously opens up again, which is what happened here. He wasn't totally occluded when we did the heart cath. And that explains the big washout of troponin that occurred and the relatively preserved left ventricular function. So we felt that this plaque here was the culprit, and so they decided to stent it. So let me show you just 1 second. Before I do that, let me show you the left ventriculogram. Let me get rid of this mark there. Now, they did a left ventriculogram, which is basically a moving picture of the heart beating, so you can see what the left ventricle is doing. And so there's a little hand injection there. Let me play that back. What you see is the anterior wall, which is over here, is contracting fairly vigorously. Oops, let me give you that. I didn't show you that shot there. So I wonder if did I mess up? Okay, so hold on a second. Let me go back and make sure that you guys actually saw the angiogram, because now I'm getting a little confused with my shots here. So let me play this back just to make sure that you saw what the right coronary artery looked like. Okay, so here it is. So there's that lesion that I was referring to. That's the left ventriculogram. So here's the lesion I was referring to. And we were talking about a severe stenosis that winds up getting occluded by platelets and a small thrombus, and it causes an acute MI, but then spontaneously opens up again. Okay, everybody seeing that? Okay, so now let me play the left ventriculogram. Okay, so with the left ventriculogram, this is the anterior wall, and the inferior wall is over here. And if I play that back again, what you might be able to appreciate is that the anterior wall is contracting fairly vigorously, but the inferior wall is sort of like lagging behind a little bit. It's just a little bit under. It's not contracting as vigorously as the anterior wall. Oops, let me get back again. So here you have vigorous contraction, the inferior wall a little less so. Okay, so they decided to go ahead and put a stent in. So there's the vessel. Now what you see is a guiding catheter, and you have a guide wire, an angioplasty wire. Let me erase these lines, which is going down the right coronary artery, down to where that blockage is. And right here, they have the stent, which they're inflating and smushing that plaque against the wall and leaving a stent behind. And look at the result. This is the final result with the right coronary artery. So remember, this is what it looked like before, with this big nasty plaque and the bite taken out of it. So here's the stent being inflated, and here's the shot after the stent. Isn't that cool how they were able to open that up? Well, they wanted to do more than that. They wanted to make sure that that complex lesion in the circumflex wasn't a problem as well. So they went to the circumflex, and as you can see, it really is a complex lesion. It's long, it's ragged. There's a lot of stuff going on, and it's at least like 60 or 70%. So I'll play this for you. They went and put a stent in, repositioned it. Now they'll inflate that stent. It's a very long stent, as you can see. And when they take another shot, you know, it's a lot better, but there's still some roughness, some irregularity of the lumen there. So they decided the stent wasn't fully deployed. And so they went back and took another balloon, something a little shorter but higher pressure, to kind of smush that plaque out of the way and fully deploy the stent. And then you see the final result here. Ah, look at that. It's like a nice cup of cold sweet tea like I used to have when I was in Tennessee. Y'all, just refreshing. So anyway, that was the final result. And the patient actually did really well. So we were very pleased with that. We identified the patient, but now what do you do? Well, it's pretty obvious. You have to advise the patient that he really kind of did this to himself. I mean, yes, he had a family history and you can't change your genes. Well, I guess you can, but just kidding. Genes that you're wearing, get it? But he has to quit smoking. We have to get him on good cholesterol-lowering medications. The triglycerides might be making things worse. He also obviously has diabetes and he needs to be treated for that. So major risk factor reduction is the key, as well as exercise, losing some weight, and basically getting back in shape again. But I just thought that this ECG, this first ECG that I'll go back to for a second, it was subtle enough that I think a lot of physicians might have missed that. And they would have taken this 40-year-old and said, oh, well, it's probably fine. We'll just maybe do a stress test as an outpatient. But this subtle ST depression, I mean, you're used to seeing giant ST depression, you know, like tombstones, right? That's what they show you in the books. But this is much more subtle, and make sure you don't fail to recognize that, because if they had done a stress test or if they had sent the patient home, it could have spelled disaster for the patient. So I hope this was helpful. This was kind of a show and tell between the ECG and the angiogram. And I think this is probably, if you talk to plumbers, if you talk to the interventionalists, this is just a routine case. But from an ECG standpoint, it's something that you should be able to recognize. Now, I'm always talking about arrhythmias, so this is kind of a little bit of a departure for me. But I thought it was interesting enough to present it to you as a live case, a live stream. If you enjoy this content, please just scroll down to the comments and you'll be able to click on the YouTube link and subscribe to my YouTube channel, ECG Doc. That would be great. Then you'll get notification that I'm doing these. I'm trying to do them every week, and I hope you enjoy them. If you want to learn more about learning to read complex ECGs, then in the description you'll also find a link to ecgacademy.com. By the way, I also have a new website, and I wish all of you would check it out. It's called heartrhythmcentral.com. And these are mostly patient educational articles that I wrote, but there's a lot of stuff in there about atrial fibrillation and blood thinners and syncope, and there's even some stuff on POTS, because I see a lot of patients with POTS here in New Jersey. So until next week, this is Dr. Nick Tullo, and I really appreciate your being here with me, and hopefully we'll see you next week.